So if you ask a cartographer to map a continent, um, they'll eventually hand you a document with exact, undisputed coordinates.
Right, something very definitive.
Yeah. But if you ask modern medical science to map the exact location of female pleasure, specifically the G spot, you just start a massive fight.
Oh, absolutely.
Yeah.
A multi-million-dollar fight,
Well,
honestly.
I mean, you would think with all our advanced imaging and centuries of anatomy, we'd have a totally definitive map by now. But the geography of female sexual anatomy is heavily contested, it's constantly evolving, and currently it is the target of a booming aesthetic industry.
Which really leaves the average person in a difficult position.
Yeah.
We prefer our biology to be simple, like the femur is here, the left ventricle is there.
Exactly.
But the pelvic floor completely defies that kind of simple categorization. It's this highly dynamic ecosystem, and attempting to just pinpoint one specific center of pleasure has led to an explosion of commercial treatments, making some very bold promises.
Welcome to the deep dive. Whether you're actively evaluating intimate wellness options for yourself, or you are just insanely curious about the underlying science of aesthetic gynecology, you are in the right place. Today, we're tackling a central mission. Can the highly marketed O-Shot actually improve G-spot sensitivity?
And it's a question that is just fraught with conflicting data. So we're going to cut through the heavy clinical jargon and the glossy clinic marketing to understand exactly what the science says.
Because in this space, the marketing is definitely outpacing the evidence.
Oh, without a doubt.
So to get to the bottom of this, we've pulled a huge stack of sources. We've got a brand new 2026 prospective pilot study comparing injectables, a massive 2025 systematic review of 17 different studies out of the Revista Ibero-Americana, clinical guidelines from NICE and ACOG, and the fascinating anatomical history of the G-spot itself.
But before we can even talk about sticking a needle into a specific spot to improve sensitivity, we kind of have to ask what and where exactly is the G-spot?
Right, like does it even exist?
Biologically speaking, the definition has undergone a massive paradigm shift. If you look back at the origins in the 1940s and 50s, Dr. Ernst Greifenberg described this very specific erogenous zone along the front wall of the vagina.
Which is the anterior wall, right?
Yep, the anterior wall. He said it was closely associated with the urethra. And that is where we get the G in G-spot.
So he essentially described it as this distinct, localized anatomical button, just a cluster of nerve endings independent of the clitoris waiting to be pressed.
Exactly. And for decades, that was the accepted medical and cultural narrative. You just had to find the right coordinates.
But the modern anatomical plot twist is wild because major medical groups and researchers completely reject that isolated button theory now.
They do. Researchers like Australian urologist Helen O'Connell and the French researchers Odile Buisson and Pierre Foldes, they used MRI technology and 3D sonography to look at the internal anatomy during sexual arousal.
And their imaging basically upended everything we thought we knew.
Totally. They demonstrated that the erectile tissue of the clitoris extends way, way beyond what you can see externally. It has these deep internal roots and bulbs that are incredibly substantial.
Yeah, the fMRI scans from the Rutgers study in our sources show that during arousal, these internal clitoral bulbs engorge with blood and actually wrap around the anterior vaginal wall.
Right. The clitoris is effectively hugging the vaginal canal from the inside.
So a vaginal orgasm is likely just the internal stimulation of the clitoris being pulled closely to the wall during penetration.
Precisely. The literature now refers to this whole area as the clitorethrovaginal complex. It's not a standalone structure.
There's an analogy from the Rutgers study that researcher Barry Komisaruk uses. I love it. He says the G-spot is like New York City.
Well, that's a great way to put it.
Right. Like it's not a single thing or a specific address. It's an entire region, a convergence of the clitoris, urethra, and vagina. But if it's an entire neighborhood, how can a doctor possibly target it with a needle?
Well, that structural dilemma is exactly where the aesthetic clinic steps in. Because it's a complex neighborhood, clinics have developed two very different treatment philosophies that you'll see marketed.
The G-shot and the O-shot.
Exactly. And their underlying physiological goals are completely different.
Let's start with the G-shot. This one is basically a structural intervention, right?
Yeah, it's fundamentally a dermal filler. The practitioner injects cross-linked hyaluronic acid into that anterior vaginal wall.
Cross-linked meaning it's a dense gel that won't dissolve immediately.
Right. If they just used liquid hyaluronic acid, your body would clear it in days. The gel resists that, so it temporarily increases the volume of the tissue.
So the clinical intent is just purely physical.
Purely mechanical. More volume equals a tighter space, which theoretically means more friction and physical pressure during intercourse.
Okay, let's unpack this. The G-shot is essentially a structural fix. It's like adding an internal speed bump for more friction.
That is an excellent analogy, actually.
Oh,
Yes,
cool.
a speed bump.
Which brings us to the O-shot, which is a totally different beast. This one uses PRP, or platelet-rich plasma.
Right, and this is a cellular approach.
So they draw the patient's own blood, spin it in a centrifuge, and take the platelet-rich portion to inject into the clitoris in that front vaginal wall. But why platelets?
Well, platelets aren't just for blood clotting. They contain these highly concentrated growth factors. We're talking about things like VEGF, PDGF, and TGF-beta.
Which are basically the body's construction workers?
Exactly. The goal with the O-shot isn't just physical pumping. It's biological regeneration. The VEGF stimulates brand new blood vessels, which is called angiogenesis.
Oh, wow.
Yeah. And the PDGF enhances collagen production, and they even theorize it promotes nerve regeneration.
So if the G-shot is a structural speed bump, the O-shot is a biological fix trying to actually heal tissue and grow new nerve endings.
You nailed it. That's the exact difference in the marketing pitches.
Okay, so the premise sounds amazing, but the million-dollar question is, do they actually work when put to the test in clinical trials?
That is where things get really complicated.
Let's look at that brand new 2026 prospective pilot study by Barber and Igoulouz. They took 16 women and split them up to test the injections.
Right, using the Female Sexual Function Index, or FSFI, to score their improvement.
And the numbers look incredible at first glance. The hyaluronic acid group, the G-shot, saw a massive 68% improvement in their scores.
Which the researchers attributed directly to that immediate volumetric friction effect.
Yeah. And the O-shot PRP group also saw a huge significant improvement of 45%.
So if you just read that one pilot study, you'd think, wow, medical breakthrough.
Exactly.
But we have to contextualize this with a broader, much more cautious perspective. If you look at the 2025 systematic review of 17 different studies, well, the data is incredibly messy.
Messy how?
There is huge clinical heterogeneity.
Meaning everyone is doing it differently.
Exactly. Clinics are injecting anywhere from 2 to 10 milliliters of PRP. They're using completely different centrifuge spins, which changes the platelet concentration, and they're targeting slightly different spots in that pelvic neighborhood.
So it's not standardized at all.
Not even close. And that review pointed out a massive red flag. There was a 2024 randomized controlled trial by Waga and colleagues.
Oh, a randomized controlled trial. Those are the gold standard.
Right. They actually compared the PRP O-shot to a saline placebo.
Here's where it gets really interesting. What did they find?
They found absolutely no statistically significant improvement in FSFI scores for the PRP compared to the placebo.
Wait, really? The 2026 pilot study shows a 45% improvement with PRP, but a 2024 placebo-controlled trial says it does nothing at all. As a listener trying to make an informed decision, how are we supposed to reconcile that?
It comes down to the difference between small, uncontrolled pilot studies and rigorous placebo trials. The placebo effect in sexual medicine is profoundly powerful.
Because just investing money and focusing on the treatment reduces performance anxiety.
Exactly. When anxiety drops, blood flow to the pelvic floor naturally increases. Plus, you become hyper-focused on sensations in that area. Your brain actually amplifies the feeling. The improvement is real, but it's generated by the brain, not the injection.
That is wild. And there's another crucial detail from the Women's Health Clinic source about the aftercare for the O-shot that just blew my mind.
Oh, the NSAIDs restriction.
Yes. If a patient gets an O-shot, they cannot take NSAIDs like ibuprofen or Advil for a week before and a week after the procedure.
And the reason why is fascinating biology. NSAIDs chemically deactivate platelets.
They completely stop the growth factors from working.
Right. They block an enzyme that the platelets need to burst open and release all those regenerative factors. So
Yeah.
if you take an Advil for a headache after spending thousands on an O-shot,
You just turned it into an incredibly expensive injection of inactive fluid.
basically, yes. Which really highlights how fragile this mechanism is.
So building on this shaky clinical evidence, what do major medical bodies actually advise listeners to do?
Well, I have to drop a hard truth here. Procedures like the O-shot and G-shot are widely considered investigational.
Meaning they aren't approved.
Correct. The FDA, the MHRA, and the American College of Obstetricians and Gynecologists, ACOG, they do not endorse them.
ACOG actually has a really severe warning about G-spot amplification. They say it has no valid medical reason.
None at all. and it carries severe risks. We're talking about scarring, tissue adhesions, and ironically, it can actually cause sexual dysfunction.
Because injecting a dense filler into a highly sensitive neural area can create microtrauma, right?
Exactly. And when that trauma heals, it forms fibrosis or scar tissue. Scar tissue doesn't stretch or engorge. So you're literally preventing the natural arousal response you were trying to enhance.
Wow. Now, our sources do point out that energy devices like the Emcella chair or vaginal lasers do have clinical evidence.
Yes, but there's a major caveat there. The evidence for those devices is for functional pathologies, like using lasers for severe tissue thinning in menopause, or the Emcella chair for urinary incontinence.
So any improvement in sexual pleasure from those devices is purely a secondary game.
Right. If you fix severe dryness or strengthen a weak pelvic floor, of course, an intercourse becomes more comfortable and engaged. But the device didn't manufacture a heightened state of arousal out of nowhere.
That brings up a critical myth bust from the clinical guidelines regarding primary anorgasmia.
Yes, this is so important.
If someone has never had an orgasm in their life, the issue is highly likely to be neurological or psychological, right? Not structural.
Exactly. Injecting hyaluronic acid to create friction is not going to spontaneously forge a new central nervous system pathway. An injection will not create a new function where none existed.
So what does this all mean for you? It means before spending thousands on a trademarked experimental injection, you should really look at the foundational treatments that the medical community actually stands behind.
And clinics have true, evidence-based first-line treatments that they recommend trying first.
Like topical estrogen.
Yes, which is the absolute gold standard for treating the genitourinary syndrome of menopause. It restores the tissue safely.
And what about for muscular pain or tightness?
Pelvic floor physiotherapy. A specialized PT can map the muscles and release tension that's restricting blood flow.
And for low desire, the guidelines mention systemic HRT or even off-label testosterone therapy.
Right. You treat the fundamental biological drivers first before resorting to investigational aesthetics.
So, to summarize our deep dive today, the O-shot uses growth factors that might biologically improve tissue health, and the G-shot might offer mechanical friction.
But the G-spot itself is a highly complex neighborhood of clitoral roots and nerves. It's not a single button.
And the science of injecting it is still very much in the experimental phase. It lacks standardized protocols and long-term proof.
It really does. But I want to leave everyone with one final, mind-expanding idea drawn from that Rutgers fMRI study.
Oh, this is the best part.
Because the aesthetic industry focuses completely on manipulating the pelvic floor tissue. But when researcher Barry Komisaruk scanned the brains of women during stimulation,
He found something incredible. The brain scans showed that stimulating the clitoris, the vagina, and the cervix lit up totally distinct, physically separate areas of the sensory cortex in the brain.
right, even though those tissues are all physically woven together in the pelvis, the brain does not process them as one big blurry event. It isolates them perfectly.
So, if our brains are mapping these distinct feelings so specifically, maybe the future of sexual medicine and solving orgasmic dysfunction doesn't lie in injecting the pelvic floor at all.
Exactly. The bottleneck might not be in the pelvis. The future is probably in understanding and unlocking how the brain itself processes these converging signals of pleasure. Neuroplasticity over needles.
I love that. Neuroplasticity over needles. Thank you so much for joining us on this deep dive. We hope this empowers you to keep asking questions, protect your wallet, and always demand good science.